Welcome everyone who has joined to us. Today we are going to talk about the spinal cord. It is a part of central nerve system and a basic overview of the ascending and descending tracts of white matter of spinal cord. And you know that we have a lot of video on our page in the Moodle here, as usual we have many links to a video that tells in more detail about the function of this organ and in general a lot of video files with different descending and ascending tracts of spinal cord. Let's start. We will return again to the slide that shows the structure of the nerve system, and we have already considered the periphery of this part of the slide, and now we are moving to the central part, central nerve system, and here we are now spinal cord. And what we are now, there are several functions in the spinal cord: conductivity, integration, locomotion, reflexes. And about conductivity we will talk about this function almost all this practice, and next practice about reflexes. Almost all next practice will be discussed about reflex. So this function, it's conductivity, that we will consider today in detail, and today we will meet a lot of new words and anatomical terms. So much new words that I even do the special slide. White matter, you know, gray matter, tracts, horns, central channel, posterior dorsal root, anterior ventral root, lateral horn, afferent, contralateral, commissure, testo, reticula, ganglia, fissure, and sulcus. You know these all terms, I hope, from anatomy, but just like your dictionary about spinal cord terms. And about anatomy a little bit more. Spinal cord is a cylindrical structure that runs through the center of our spine, of animal spine, from our brainstem to our low back. It's a delicate structure that contains nerve bundles and cells that carry a messenger from our brain to the rest of our body. Our spinal cord has main parts: cervical part, neck, thoracic, just chest, and lumbar, lower back, and even sacral part. And for animals, you know the parts of cauda. And each part is represented by segments. We already talked about this when we studied nerve fibers. In animals, I give you this information about spinal cord segments and some common species, and total account of vertebrae and spinal segments for each animal. And I hope you remember the dermatomes and myotome structure and how it's important for local anesthesia. I leave the links to the practice about physiology of nerve fiber, and for humans the same, almost the same, and you know this very important refractory activity. And let's start the anatomy of the spinal cord. And the spinal cord is under the protection of the bone in the spinal channel of the spine, And in addition, it's surrounded by meninges. You see here, so it's not a very good picture, but spinal meninges we will discuss later. You see, the function of spinal meninges include protecting spinal cord, carrying blood supply, and constitutes with cranial meninges. We have some meninges here. It's epidural spice, so we'll discuss about this. It's very important spice for epidural anesthesia, but here we see the dura mater, arachnoid mater, green color, and pia mater, almost very close to spinal cord. So they have their functions. This protective tissue include dura mater, the owner layers that protect our spinal cord from injury. Arachnoid mater, the middle layer between the epidural and subarachnoid spice, and pia mater, the inner layer that covers our spinal cord. And in injection of novocaine into the epidural spice can reduce the sensitivity of a big part of the body without the use of general anesthesia. At the end of the practice, we will watch the video, special video about epidural anesthesia. And here you can see the in what spice we move the novocaine, analgesic, and diffusion beyond the dura mater. And move next slide. An accurate description of the dura mater. You see this spice, the dura mater, and of course it is a fibrous tissue, and cranial caudal is different, and epidural spice between spinal dura mater and walls of vertebral channel, and contains those connective and adipocyte sites. This is a fat anesthetic injection site. Next one, arachnoid mater. Between arachnoid mater and dura mater there is a subdural spice, subarachnoid spice between arachnoid mater and pia mater, contains collagen, elastin fibers, and filled with cerebrospinal fluid. And this fluid carries dissolved gases, nutrients, and wastes from the nerve system. And one more, the pia mater, it is the innermost layer, is a match of collagen and elastic fibers, and here we see the special ligaments and a lot of blood vessels. And this slide we can see these layers of this matter. You see the very thin, almost invisible. You see, this is a real spinal cord, and even you see the dorsal root, real roots from the spinal cord. So, move deep into the nerve tissue, cross-section anatomy. Here we see the gray and white matter of the spinal cord. There is really nothing gray there. This is a special method of staining, histological slides of preparations, a nerve tissue staining technique developed by the Italian physiologist Camillo Golgi in the end of the 19th century, and the Golgi method was called the black reaction by the Golgi himself, but later it became better known as the Golgi method. Dendrites are stained brown and black, which makes it possible to determine their length and make visible the complex network structures of many parts of brain. So it's very good method for know what inside the brain or inside in a spinal cord. So here on the previous slide you see that nothing special, nothing gray, nothing white, just one color. But after studying special histology method, we can see the brown-black neurons with dendrites, axons, and white matter for fat, for myelin. We'll discuss about later. And so we see the gray matter with the cell bodies and white matter. Here we see the nucleus of neuron cells and glial cells. So the gray matter is the bodies of the neurons, neuroglia and axons without myelin. From above, everything is covered with white matter. There are many myelin axons, but there is also within myelin axons. We discussed this in practice about the nerve fiber, And now let's take a closer look at the function of the gray matter, of the segments. As you can see on the slide, the pattern is not the same in different departments. As you can see, the gray matter is involved in a lot of important body function because it contains almost all the neuronal cells bodies. The gray matter of the spinal cord is involved in muscle movement, sensory function and sympathetic activity, and the cell bodies of alpha motor neurons presented in anterior gray column controls the activity of skeletal muscles. The posterior gray column receives sensory information from the sensory receptors present in the skin, bones and joints. And the lateral gray column is involved in the sympathetic activity in the central nerve system. The axons of cell bodies in lateral gray column, synapses with sympathetic ganglia. The upper thorax segments control sympathetic activity in the heart and thorax. White neuronal cell bodies, while the neuronal cell bodies of the lower thoracic and upper lumbar regions affect abdominal organs and pelvic organs and lower extremities. Through the lateral gray column, the sympathetic nerve system makes changes in the cardiac, pulmonary systems and more to prepare the body for emergency situation. There you see all these horns and the neurons of these parts. Here we see the different colors: visceral motor, somatic motor, interneurons, different in somatic sensory and visceral sensory too, autonomic nerve system. And here we can see all about the gray matter and all about we'll discuss later even. So in general, there are dorsal afferent neurons, ventral motor neurons and lateral horns for autonomic vegetative nerve system. It's just a text, and these neurons, you see this circle, these neurons create functional association. These are nerve nuclei or nerve centers. There are a lot of the cells, and they do not look like globules. They have different shapes, but in the spinal cord they are elongated structures, long structures, and in the brain we can find just a global, this nuclear like a global, like this prolonged structures and different shape. Each nerve center controls certain function. And we'll discuss about all nerve center function later, very soon. But now, in spinal cord, we will discuss about white matter in the spinal cord, and you see white column, bundles of myelinated axons that provide avenues of communication, carry signals up and down to and from brainstem. We can find 3 pairs of columns or funiculi, dorsal, lateral and ventral columns, and each column is filled with named tracts or facilities. Fasciculi fibers with a similar origin, destination and function. This is a process of neurons, axons covered with myelin that conduct signals. They are divided into ascending ones that carry signals to the brain and descending ones that carry signals to the periphery. And now, as well as the gray matter, they are called dorsal, lateral and ventral. You should be ready to a lot of different synonyms. Synonyms with the name of this. Dorsal white, for example, you see here we see gracilis and cutaneous fasciculus, but in general we can name the difference. The name of scientists which discovered this column, these tracts, and sometimes we can see this photo in this position, but sometimes we can to change position of the picture, and I will set that the position in changing place. In addition, the tracts can change the site. Site of the spinal cord. Example on the site. For example, the site here. Next slide. Here you see the changes of the position from the right side to the left side and move up to the brain on the left side of the cortex. So the sensitivity, sensory impulse from the skin from the right side of the body move in the right side of the spinal cord, then change the position on the left side and move in the left side of the cortex of the brain. So it's very important information, and about these synonyms in the name you see, and the position of the spinal cord a little bit move. Here we see the one place of the anterior corticospinal tract, and here we see in the upper part of the picture. So when the tract changes the site, this is called the contralateral tract. Ipsilateral, belonging to our occurring on the same side of the body. If we don't change the position from the right side to the left. Ascending parts on his way. Here we see an example. These tracts undergo decutation crossover as they pass up or down the cord, when origin and destination are on opposite sides, contralateral, when origin and destination are on the same side, ipsilateral. So ascending tracts carry sensory signals up. the spinal cord. These signals will travel across 3 neurons from the origin in the receptor to the destination in the brain. First order neuron detects the stimulus and transmits the stimulus to the cord or brainstem. Second order neuron continues as far as the gateway, as usual thalamus, and third order neuron carries signals the rest of the way to the central region of the cerebral cortex. And here we can see this example: first order neuron, the second order neuron, and third order neuron. It's typical way for sensory information. And consider 6 ascending tracts, 2 each dorsal, ventral and lateral, and we will discuss about all these tracts. Here you can see a comparative description of the 2 ascending dorsal pathways, and Fasciculus. They are also called Golgi and Burdaha. Here you can see these names: Tract of Goyle and Tract of Burdach. It's just names of scientists. The function of these tracts, sense of touch and vestibular transmission of sensation, consequence proprioceptors, tendons, ligaments of the joints. We studied this in the muscle section. Somatic visceral pain from muscles, for example. According to sensory signals, both tracts are very similar. Here we can see this photo, very similar, and here are the actual neurons of these tracts all the way to the thalamus, and you see carrier signal from different organs in the skin, and 2-point discrimination. It's a point of touch. You know that we can't detect how much fingers touch our skin on the back, 2 or 1. So it's a sensitivity from 2-point discrimination, as it's from proprioceptors too. So let's start from the cutaneum, Fasciculus. How I said, according to the sensory signals, these tracts were similar, and here we see the first order neuron, actual neurons of these tracts, and all the way to the thalamus, the first one, cell body from the receptors, you see, and there is a description showing the segments of the spinal cord and the destination in a thalamic area in thalamus. The following tracts are the anterior, this ventral posterior lateral nuclei in the thalamus area in the brain, and following tracts are the anterior and lateral spinothalamic tracts. So it's just previous one, and here spinothalamic tracts, anterior and lateral spinothalamic or ventral tracts. Send signals of pain, temperature, pressure to the thalamus. Here is the same place like in the previous two tracts, and here what we can see is the spinothalamic tracts, anterior or lateral and lateral. The same, almost the same, light touch and reception of the pain and sensory input. Here we can see the anterior spinothalamic tract, light touch and pressure impulses from the skin, from the special elements, Merkel's tractal disc, and first order neuron, dorsal root ganglion, all levels, second order neuron in the dorsal horn, cross to the opposite side, ascent in the contralateral ventral column, and in ventral part, nucleus of the thalamus, and third order neuron, you move in thalamus, project to the central cortex area, and here you can see, but the area has the number 3, 1, 2, and I will watch the next one, this area, different parts of the cortex in the brain. So about lateral spinothalamic tract, almost the same, pain and thermal impulses, input from the free nerve endings, thermal receptors, transmitted to spinal cord in a delta and C fibers, and central processes enter the spinal cord through the posterior nerve root, proceed to the tip of the dorsal gray column, and second order neuron in the dorsal horn cross to the opposite side, so they change the position from the right side, for example, on the left, and from the left on the right, and in the nucleus of thalamus. And third order neuron from the thalamic area project to the cerebral cortex, and in a different area, primary sensory area, and we have 1, 2, 3 parts of this area. So, and next one, what I want to say is that these tracts, unlike the previous ones, form a crossing to the opposite sides in total. The following tracts are the Spinocerebellar tracts. Cerebellum, it's the previous one. Here we can see where this position, lateral spinothalamic and anterior spinothalamic tracts, and the changes of position from the right side to the left part of the cortex. So next one, spinocerebellar tracts, anterior and posterior, two tracts, and one change the position from the side. And here we see transmit unconscious proprioceptive information to the cerebellum. So it's very important tracts for the animals, because a lot of movements in animals' body are unconscious. Receive input from muscles, spindles, and pressure receptors involved in coordination of pose and movement, position of the body, of individual muscles of the lower limb, and here we can find this cerebellum. So it's here anterior spinocerebellar tract in lateral white column of spinal cord, and posterior spinocerebellar tract in posterior lateral white column of spinal cord. And here one more, cerebellum, and here we can find posterior spinocerebellar and anterior spinocerebellar tracts. So it is the location of these tracts, but about neurons carry proprioceptive signals from the limbs and trunks to the cerebellum, and first order neurons originate in the muscle and tendons and end in a dorsal horn of cord. The second order neurons send fibers up the spinocerebellar tract and in the cerebellar. And ventral tract cross over and travel contralateral up the cord, then cross back to the cerebellum. Dorsal tract travels, change the position, ipsilateral up to the cord to the cerebellum. So with a change of position. So here we see the one more tracts, and I want to add one more tract, spinal reticular tract. You see, it's a little unusual. This tract is connected with the reticular formation. Here in a red colored circle. This tract is connected with the special reticular formation by the short fibers. Red horn is a very sensitive part of the brain, about which we will learn more soon. And dorsal olivar tract very short to leaves of medulla oblongata, and here we see the position this olive in the medulla oblongata. So this tract is not very long. Now descendant tracts, slightly unusual position in a slide. I change the position from the dorsal to the ventral, and it's more usual. Here descendant tracts, and what we know about it. Descendant tracts, we will discuss about four: corticospinal tract, tectospinal tract, reticulospinal, and vestibulospinal. So about names, if you see the part of the brain and the ends of the word spinal, so it's tract always descending. If you see the part of spinal and the first part of the word, and for example reticular, it's part of the brain, so this tract always give information for the brain, so up. And if the part of the brain ends in the end spinal, so down. So and descendant tracts in general carry motor signals down the brainstem and spinal cord. Involves two neurons. Upper motor neuron cell body is located in a cerebral cortex or brainstem and has an axon that turns on the second one neuron, the second lower motor neuron. And this motor neuron located in a brainstem or spinal cord, and then its axon leads to the muscle or other target organ. And corticospinal tract, divided into lateral and ventral, carries signal from the cerebral cortex for precise, finally coordinate limb movements. These fibers for the pyramids of the ventral side of the medulla oblongata, pyramidal tracts, and here we can see the picture. Corticospinal tract. Areas from the pyramidal cells of the cerebral cortex. It's very big neurons with the shape of the pyramid. Fibers travel through corona radiata, posterior limb of the internal corpuscle, central cerebral pediculi, middle from the 3 and 5 spons, medulla oblongata. Eventually fibers cross the midline that terminate in parts of gray metacolumns and repressive spinal cord segments and some neurons. And next, descendant motor tracts. Tectospinal tracts origin in the tectum of midbrain. Moves the signals for reflexes, turning of head in response to signals and from the eye, ball and sounds. Reticulospinal tracts origins reticular formation, lateral and medial divisions, controls limb movements, important to maintain pose and balance of the body. Contain descending analgesic pathways that reduce pain signals to the brain. And vestibulospinal tracts originates in vestibular nuclei, lateral and medial divisions, and postural muscle activity in response to inner ear signals, maintains proper orientation in feeling. So these tracts for first one, tectospinal tract, and here nerve cells in superior colliculus of the midbrain and move down. Nerve fibers axon cross the midline, descend cross to medial longitudinal fasciculus and terminate in the anterior gray column of upper cervical segments of the spinal cord. And next, reticulospinal nerve cells in reticular formation, and this formation move from the cortex, especially the part of thalamic area, and all pons and medulla oblongata to the spinal cord, and the anterior gray column of spinal cord control activity of motor neurons. And next one, rubrospinal tract, nerve cells in a red nucleus, and from the red nucleus move fibers, axons cross the midline, descend as rubrospinal tracts through pons and medulla oblongata, terminate anterior gray column of spinal cord, and flexor of muscle facilitate the activity of flexor muscles. And we will discuss about red nuclei and the damage some part of the brain, and medulla oblongata can have the symptoms like dead cerebral rigidness. Vestibulospinal tracts, you can just read the text. And it is the end of our practice, but we want to discuss about epidural anesthesia and to watch the video about epidural anesthesia. So let's start to watch the video. It's at first it will be the cow, and the next it is a dog.
Now I'm going to demonstrate epidural anesthesia. This is a very commonly used technique in cattle practice and has many uses that I won't go into here. The first and most important aspect is to be sure that the site for epidural injection is thoroughly clean. It's best if it's clipped or shaved, and the site that we would like to use, be appreciated here when I move the tail, have slight movement at that point. And if you have some question about the disposition of the animal, it would be best to stand off to the side or kind of in a frontward position so that she doesn't kick you. Now there's some tests to determine when this needle is in the right spot. You can see that approximately 1 inch of that needle is buried. I felt that it went through some ligamentous tissue, and now it's resting just onto bony tissue, and I've withdrawn it just a very small amount. One test is to put a small drop of the local anesthetic in the needle, and if it pulls it in, as it did there, almost for certain there's an area with a slight vacuum, and that means that it's the epidural space. There I'm putting several drops in, they're all disappearing down into the needle. So that's the correct site. As for the anesthetic, I'm using lidocaine, and I'm also measuring the dose to be approximately 1/2 cc per 100 pounds of body weight. So if this heifer weighs about 600 pounds, we're going to give about 3 cc's. That will be just enough to get anesthesia to the perineum. Will not put this cow down. At that point, we'll attach the needle, stay in the same site, and make an injection. Now this plunger should almost fall in. In fact, one other test is when you're pushing on the plunger of a disposable syringe, you shouldn't blanch your thumbnail or you're not in the right spot. There it went in, then you withdraw the needle. The alternate site is at the next space, and I'll just point out where that is. Right there is the site I entered. Here is the first coccygeal vertebra, and right there would be the second site, and the needle would be thrust in right there. That's in the second site. So here's the first one, there's the second one, to give an idea about how far apart they are. The test for successful epidural anesthesia is to grasp the tail, shake it back and forth, and check for laxity. This cow has no control of her tail, she's just totally limp. Not only that, she has no sensation of pain upon pinching, and even if you get to a sensitive area like the vulva, pinching of the vulva as hard as you want raises no sensation. And then you can test the loss of sensation all the way down her rear parts as well. Now I'm going to demonstrate epidural anesthesia.
is an epidural? Epidural anesthesia is when a hollow needle, as well as a flexible and small catheter, is inserted between the spinal cord's outer membrane and the spinal column within the lower or middle back. This area is numbed using a local anesthetic. The needle is then inserted and removed once the catheter passes through it.
For purposes of demonstration today, we're going to use the L4-L5 interspace, but in fact, any interspace below the level of the second lumbar vertebra may be employed in an obstetrical epidural anesthetic. A long needle known as a TUI needle is first advanced into the soft tissues between the spinous processes of the fourth and fifth lumbar vertebra. A syringe containing a few cc's of saline is attached to the TUI needle, with the operator maintaining a light but steady pressure on the plunger of the syringe. The needle and syringe are advanced steadily through the interspace. Once the tip of the needle is advanced into the epidural space, the operator notes a release of the syringe plunger as the saline squirts into the space. The epidural catheter is then inserted through the TUI needle. Owing to a slight curve at the tip of the TUI needle, the catheter is directed upward, approximately 4 to 5 centimeters into the epidural space. The TUI needle is then removed. To ensure that the catheter is properly placed in the epidural space and not within the dura and arachnoid coverings, a syringe containing a small dose of anesthetic, typically lidocaine, is attached to the catheter and injected. A minimum of 3 minutes after the test dose, the patient's ability to move their lower limb is tested. If the patient is able to move their lower limb, this indicates proper placement of the epidural catheter in the epidural space. If the lower limb cannot be moved, then placement of the catheter within the dura and arachnoid layers must be assumed. This is also known as an intrathecal catheter placement and requires that the catheter be removed and the placement procedure started over. Once proper placement of the catheter has been ascertained, a bolus dose, consisting typically of about 10 cc's of anesthetic, is injected through the catheter to initiate the anesthesia. A continuous infusion of anesthetic is then initiated. The rate of the infusion may be adjusted according to the patient's response and the level of anesthesia desired.
What is a spinal? The spinal anesthesia is a single shot technique that mainly involves injecting a set of local anesthetics into the subarachnoid space. Normally, for spinal anesthesia, low volumes of local anesthetic drugs are used. This technique uses a fine hollow needle with a diameter only slightly larger than a horsehair. Less diameter of the needle makes penetration process easier. Once the anesthetics are deposited to the spinal fluid, there is a mixed amount of hours, around 2 to 3 hours, that it will work. So what is the difference between a spinal and epidural? A spinal is simple, rapid, and reliable, though an epidural has a longer onset of time than a spinal due to the catheter. A spinal technique is more economically sound since you use less drug volume than an epidural. Another difference is spinals are administered directly into the spinal sac, while epidurals are injected into the area around the sac. Risks of postoperative damage from this anesthesia are slightly lesser when you are going for a spinal.
So, we know that the spinal cord anatomy and physiology are very important to the next year and for surgery, especially for you homework for your homework. In a book Animal Physiology, you just have to read the pages about nerve system, and see you next time in a spinal cord, but we will discuss about reflexes. This will be practice for reflexes of spinal cord. Bye bye.